Okay, boleh nampak saya punya screen?
Boleh?
Boleh. Okay, Assalamualaikum and good morning to every one of you. Okay, today I will present about gliomas. And first of all, I want to thanks to the IAP committee for giving me an opportunity to share my knowledge and experience in neuropathology. So initially, it's quite difficult for me to choose the topic because Dr. Zara said it's supposed to be relaxed, weekend. But when we talk about brain tumor, it's difficult for me to be relaxed lah. So this topic I choose because the most common that we've encountered in Malaysia, also in other parts of the world. Okay, so my presentation outline will be, I will be talk about facts about brain tumor, brain tumor classification, gliomas, facts about glioblastoma, and then a bit about glioblastoma, also a revolution of diagnostic and also summary. Actually, I have a full spectrum of gliomas. So maybe in between of this presentation, I will share some case or cases scenario. So it will be more exciting. Okay. Okay. So first about facts about brain tumor itself or brain cancer. So brain cancer actually is the 10 leading cause of death for both men and women, and the 5-year survival rate for both for people with cancerous brain tumors is about 34% or only 36%. And for glioblastoma, the 5-year survival rate only 5.5%. And what is the worrying thing is the drugs, the FDA approved drug for brain cancer is only achieved after 30 years they did the research. Okay, so I don't know you all aware or not that we have World Brain Tumor Day with this ray pink. So they will be every 8 brain tumor. Brain tumors is most common group affected children, and the most common gender affected is men. And there are over 120 different types of brain tumors. And brain tumors drastically affect physical cognitive abilities and cognitive abilities, and also quality of life. So although as many as 60% of children with brain tumors will survive, but they are often left with long-term side effects. So this GloboCan is actually Global Cancer Observatory. They estimate the incidence of brain and other CNS tumor in Eastern Africa, 18 countries, to be 1.2 per 1 million. Okay, so in Southeast Asia, brain and nervous system cancer is top 10 of deadliest cancers also. This is in 2017. Okay, sorry. But for Malaysia itself, actually it's quite difficult to get research. So I just found one research in 2017 also, which is did by, I think, HUSM. I think they did demographic research. It's about distribution pattern of brain tumor in tertiary hospital in East Coast Malaysia, and they found that in Malaysia, most common gender affected is female. with more than 45 years old, and the most types affected is actually meningeal tumor, and the second is astrocytoma, and followed by secondary tumor. Okay. From this astrocytoma, actually glioblastoma, giving a quite high number, is about 7.8%. Okay, so what is the further brain tumor classification? So as I mentioned before, I will focus more on the gliomas. Okay, so we look at WHO classification first. As you know, we have a new WHO classification, fifth WHO classification this year. So there is a journal. This journal actually they try to summarize the major general changes in the 2021 fifth edition classification and the specific changes in each taxonomy category. So it helps. It hope that this summary can provide an overview to facilitate more in-depth exploration of the entire fifth edition WHO classification, the latest one. Okay, so if you look at the evolution of the WHO itself, we start in 1993 as a first edition, and then now 2021 is fifth edition. Okay, and then I don't know you're all aware or not that actually for this WHO CNS, we have this T impact now. This T impact now is like committee that doing all the evaluation assessment to have the further classification for WHO. So this C impact now update 6, which most correlate with our latest WHO. This is the team, okay. And then what is the impact now is it is the consortium to inform molecular and protocol approach to CNS tumor taxonomy. So they try to provide a forum to evaluate and recommend proposed changes to future CNS tumor classification. So first round was from 2016-2019, and they will publish 4 updates, and which is incorporated in our latest WHO 2021. So this is okay, this is our latest WHO classification of tumors. Okay, it's actually the new classification is mainly molecular related. Okay, but I will focus on the gliomas today. So general changes in WHO classification 2021, they have talk about the CNS tumor taxonomy, nomenclature, and then classific gene and protein nomenclature for CNS tumor classification, grading, NOS and NEC diagnosis. Also the novel diagnostic technologies, integrated and layered diagnosis, as well as new recognized entities and revised nomenclature. But for the specific changes, it touched actually almost all of the tumor, CNS tumor. So that's why I cannot, I cannot touch everything. So I will focus more on the gliomas, which is most common. Okay, so now we go for gliomas in WHO 2021 classification. So they try to classify the gliomas into diffuse and circumscribed. And for diffuse, they divide into adult type and pediatric type. For pediatric type, they divide further into low grade and high grade. Okay. So for adult type diffuse gliomas, it has only 3 groups of classification, which is astrocytoma IDH mutant, oligodendroglioma IDH mutant, and 1p90q co-deleted, as well as glioblastoma IDH wild type. So no more glioblastoma IDH mutant. So if glioblastoma IDH mutant is actually falls under this astrocytoma IDH mutant category. Okay, and no more oligoastrocytoma as well. Okay. For pediatric, they have they divide into low grade and high grade. Actually, this diffuse astrocytoma MYBL is a new entity as well. So I think a few new entities here. And for high grade, we have this diffuse midline glioma and all this thing. But I cannot talk about pediatric because it also take quite a long elaboration in this. Okay, for circumscribed astrocytic gliomas, as we know, they have pilocytic and then pleomorphic astrocytoma, choroid glioma, and then SIGA, subcranial giant cell astrocytoma. Okay, this is ependyma. So they have a lot of molecular correlated diagnosis here. And okay, so I go to because molecule is quite new to us, so I don't want to make us feel scared with all the multiple things. So I try to make it simplified for you all. So we back to our basic concept also. So in today I will discuss how we classify brain tumor, but I will focus more on the intracranial tumor diffuse gliomas in adult. Okay, so first we see the topography. So what it means by intracranial, intracerebral. So we have extracranial, which is outside the cranial, or intracranial, inside the cranial, but extracerebral. It means outside the cerebral or brain parenchyma here. But intracranial, intracerebral is inside the cranium and inside the brain. So for tumor entity, for brain tumors, tumor entity, first we must know the tumor lineage. So tumor lineage is made up by histologic features, genetic makeup, expression of RNA or proteins. And then this tumor lineage will affect the treatment susceptibility, also clinical outcome and clinical behavior of tumor progression. That's why the group that make this WHO classification try to incorporate these molecular things, because it affect the treatment as well as the clinical outcome and tumor progression. Okay, so this is basic approach how we approach the tumor diagnosis. Of course, we still need to know about the clinical and then the MRI findings. And sometimes they did lumbar puncture also or hormone blood test, especially for the germ cell tumor, and followed by biopsy. Or sometimes they did a frozen section as well. Okay, so for this, I just want to highlight how we approach the brain tumor diagnosis. That it's actually important for us to know the radiology findings, and sometimes we need to also to know the gross findings and try to correlate with the microscopy findings. So we have like basic principle for low grade astrocytoma, usually is non-enhanced lesion, and it all of them is diffuse group, but for low grade astrocytoma is non-enhanced. For glioblastoma, usually it enhanced and has this rim enhancement post contrast. Oligodendroglioma usually it is not enhanced. This is on flare actually. That's why we looks like enhanced, but actually not enhanced. And it will be diffused with irregular age. Okay. Okay, then for other classification, as we know, brain tumor, we have primary or metastasis. Okay, so for primary, we have extraaxial or intraaxial. Intraaxial, we have neuronal or glial. So glioma is under this glial cell, glial group of cells. So the most common primary brain tumors are gliomas, about 50%. Okay. So it's again about the classification. So actually I emphasize this because sometimes when we have a case, sometimes we need to look back, try to correlate with the radiology finding the nature of the tumor. Is it circumscribed or diffuse tumors? Because it may give us some hint from there. So that's why I again repeat that diffuse infiltrative tumor is diffuse astrocytoma, anaplastic astrocytoma, glioblastoma, and oligodendroglioma. while the circumscribed tumors, ependymoma, pilosity and others, most low are the low-grade tumors. Okay. So now I try to give a case scenario. Okay. This is a 53 years old female who was presented with left hemiparesis, global headache, and gag ataxia. Okay, so this is the radiology findings. So we see here the radiology findings show that the brain is diffuse or wall is swollen. Okay, and when we look at the morphology here, the histomorphology, actually it also edematous, so it's correlate with the radiology finding just now. But there is also proliferation of these glial cells. Okay, and then if we look at the gross specimen, yes, this is a edematous, and then they have the thick corpus callosum here. So what is the diagnosis for this? So actually, previously it's considered as a neoplastic gliomatosis cerebri, but now actually it's no longer considered as a former tumor. It more as a special pattern of diffuse or extensive growth of the glioma cells, which invading multiple lobes, at least 3 cerebral lobes, and they actually preserve the surrounding neuronal architecture. Okay, so it's not included into the tumoral classification. Okay, so we look at the scenario 2, 56 years old female who was presented with limbs weakness, intraoperatively noted a whitish patch at motor cortex. Okay, this one is a real case in HKL. So the information given on this, and they say intraoperatively they noted a whitish patch on the motor cortex. Okay, so when we look at the microscopy, we receive tissue fragments here, which all of them looks quite cellular, with all the hemorrhage. And then on the higher power, there are these large cells. In beginning, actually, I don't know where's the tumor was taken from. So I just see this tissue, and I saw this scattered large cells. So don't know whether this is the abnormal or the normal, or yeah, is it tumor or non-tumor? Now the question is. So when we look higher, then we found this very large pyramidal-like neuronal cells with prominent large nuclei as well. Okay. And on GFAP, actually it shows reactive changes to me. This you see like this star-like shape. This is all the reactive glial cells. Okay. And then Ki67 also very low. And on IDH, one is negative, so no mutation. And NUN is highlighted all those large cells just now. Okay, so actually NUN is stands for mature neurons. So when I clarify back the case, so I clarify where is actually the surgeon took the tissue, then they said yes, they took it from the motor cortex. So actually the previous picture that I showed you, this one is the bad cells. It's a large modified pyramidal neurons, and it's normal actually, because they still shows this enhancement at periphery. So it's a normal process. Okay, so it's a non-neoplastic process. So that's why I said that we really need to know where is the sample taken out, and then what is the radiology finding. Yeah, so the correlation is very important. Okay, so next we will think about glioma. So I try to back to the basic for glioma. So we can understand, we may have a better understand in the glioma. So glioma is actually a common type of tumor and it originates in the glial cells. Glial cell consists of astrocytes, oligodendrocytes, and also ependymal cells. Saya tak dengar sebenarnya ada apa-apa. Saya teruskan.
Boleh, boleh.
So, glioma is intraaxial brain tumors. Okay, now we try to look at the central nervous system. We have actually neuroglial cells of central nervous system as well as peripheral. So we call as neuroglia. So neuronal and glial cells. In central nervous system, in this main brain, which is consists of cerebrum, cerebellum, this one, and spinal cord, the brain stem. So the component is for neuroglia or neuroglial. So neuro is neurons, this one, which is the basic working unit. And glial cell is oligodendrocytes, astrocytes, ependymal cells, and microglia. Microglia is actually like a histiocyte or macrophage in the brain. Okay, so these all glial cells actually is the supporting cells to this neuron as a basic working unit. Okay, this is the H&E look of this glial cell. So you may see this in normal brain tissue. We will see this thin wall capillaries. Okay, and then also this scattered small cell, the glial cells. Background is the fibrillary background or neuropil, and also these large cells with nuclei. This is a neurons. Okay, and then this is a higher magnification, neuropil, glial cells, and neuron. That's why the glial cell always near the neuron because it support function of this neuron. Okay, this is the diagram. So this is our neuron just now. Okay, this is astrocyte here. It support the neuron and oligodendrocyte also. Okay, this is ependymal cell. Ependymal cell actually line up the ventricle system with the ciliated epithelium here. And astrocyte also actually functioning as a blood-brain barrier in the brain. Okay. This is other this is if I'm not mistaken is Darrow red stain, which is we are not doing this anymore. This is we do previous to highlight these astrocytes, and then this oligodendrocyte with some vacuole here, and microglia which is small. Okay, okay, this is summary of the neuroglial cell in central nervous system. So the oligodendrocyte actually myelinate the CNS axon just now. Okay, and then they provide a structural framework. And astrocytes is maintain the blood barrier, provide structural support, regulate iron, nutrient, and dissolve gas concentrations, and absorb and recycle neurotransmitters, and also form scar tissue after injury. Microglia is functioning like a histiocyte, so it's when the phagocytosis. And then ependymal cell, as I informed earlier, is line the ventricles, brain, and central canal spinal cord, and also assist in producing, circulating, and monitoring of the cerebral fluid. Okay, this is glioma cell origin and glioma stem cell evolution. This one actually I tried to introduce how the normal glial cell become a tumor. Okay, so this is the neural stem cells. It will become a neuronal progenitor cells and become a neuron. From this neuron, it can be tumor. And neural stem cell also become a glial progenitor cells and also change to become oligodendrocytes, astrocyte, and both of them also can become a tumor. However, from these neural stem cells also can straight away to be a tumor. Okay, so so that means the normal cellular hierarchy like this is comprises of neural stem cells, which can progressively produce new stem cells here, and more restricted progenitor cells finally will yielding these oligodendrocytes, astrocytes, and neurons, and accumulation of genetic mutations in these different types of cells may sufficient to induce tumor or gliomas later on. So these gliomas will contain a population of glioma stem cells, which it can be by themselves to be self-renewal capacity and ability to differentiate to all the lineage. Okay, this is another scheme to explain about just now. So it means from this progenitor cell, they may become a example this oligodendrocyte. From the glial progenitor can be become an oligodendrocyte progenitor and then become oligodendrocyte. So from these progenitor cells, it by themselves can be a tumor. So it no need to be, you know, to be oligodendrocyte first to be a tumor. From this stage also, they can be a tumor if they have a accumulation of the mutation, gene mutation. So that's why important for us to know for this all level, what is the specific gene mutation. Okay. Okay, I hope I'm not confused you all. Okay, now we go for the tumor typing. In glioma, the most common is astrocytomas and oligodendroglioma. In astrocytoma, this is a normal astrocyte, okay, and then they become a astrocytoma. So it's a cellular processes with random arrangement. Okay, for oligodendroglioma, this is normal oligodendrocytes. So when it becomes a tumor, it have this appearance, perinuclear halos with regular nodular arrangement. Okay, so we look at the next case. Okay, this is a 44 years old female presented with new onset seizure. So this is a first area. So we see here, this is a blood vessels, and we see this all the glial cells, and this is likely a neuron. Okay, and usually glial cell also normally will as I informed just now, so they surround the neuron and surround the blood vessels. Okay, so this at this level is quite difficult to say is it reactive or is it tumoral neoplastic process. But actually we already see this hyperchromatic cells here, but the cellularity is quite not convincing to say tumor yet. Okay, next we look at this area. Then actually there is more and more the hyperchromatic cell, this darkened cells. Okay, and the vessels also is not thin wall capillaries like the I show you all the normal glial tissue just now. It's already you know, a bit prominent. Okay, so is it enough for us to diagnose straight away to say what it is tumor or non-tumor? So first thing we must know, is it tumor or non-tumor, right? So we need a further information for this case. So yes, of course, I need further information, but at this level, there are a lot of differential diagnosis already. It still can be a normal brain, reactive gliosis, demyelinating disease, oligodendroglioma, because we saw the like microcystic appearance just now, like vehicle, and then pilocystic exocytoma, diffuse exocytoma. So it's still not enough to conclude the diagnosis. Yeah, so I would like to have this radiology findings. Okay, so when we look at the MRI brain, we saw this tumor is quite diffuse, with the irregular edge here, and then it not enhanced, and no rim enhancement as well. So far, no midline shift or yeah. So and we look at the gross morphology. It has this cystic appearance and no necrosis, no hemorrhage. So this time, I can conclude this is a neoplastic process, or most possible is low grade glioma. Okay. So next, of course, for the previous case, we need to do some stains to exclude the other differential. Okay, but because I focus to how we want to approach the diagnosis based on the microscopy, radiology, and gross. So we can do the FAP to highlight the lineage, and Ki67 for the proliferation index of the cells. Okay, next case is 39 years old male presented with epilepsy, and it has a right temporal intracerebral tumor, and CT scan said it's a low grade glioma. Okay, this is the microscopy. So this slide, actually we couldn't see, we just see like yes, this is an increased cellularity here with all the thin wall vessels. This is like this is a thin vessel here, proliferation of the glial cell, and it looks like it can be reactive, it can be low grade. Okay, on a higher power, then we see this kind of cells, this type of cells, this like eccentrically located nuclei with abundant cytoplasm. Okay, actually this is okay, we look at after this. Okay, this is more clearer. These cells is quite abundant, a lot. Okay, this is more clearer. You can see this eccentrically located nuclei with abundant granular eosinophilic granulocytoplasm. Okay, and they have this perivascular tumor infiltration as well, and you have this mitosis. This is abnormal mitosis. Okay, so what is the diagnosis? I think, yeah, it is a gametocytic astrocytoma. Okay, actually I tried to introduce this because we need to be aware that gametocytic astrocytoma is a WHO grade 2. It's not grade 1 because okay, why? Wait. Okay, before that, I want to share with you what CNS tumor and tumor-like lesion with gametocytes or gametocyte-like cells. Okay. It can be in the gametocytic astrocytoma, oligodendroglioma with mini gametocytes, subependymal giant cell astrocytoma or SEGA, in ependymoma, astroblastoma, reactive gliosis in infection or inflammation, toxic or metabolic leukoencephalopathy, also reactive gliosis in demyelinating disease. So you may see here, gametocyte actually is non-specific features because it may have in all the spectrum of the brain lesion, can from the reactive, toxic, infection, inflammation, tumor. Okay, so you cannot say when you look at gametocyte, then it's not straightforward to say it's a tumor. And for gametocytic astrocytoma, actually the cutoff is 20% of the gametocyte to and correlate with other things, then you may say it's a gametocytic astrocytoma. Okay. So, however, for this gametocytic astrocytoma, 7 years after initial surgery, it developed this. Okay. So if you see, this is actually higher grade tumor where you look at this. Actually this is palisading necrosis. This is necrosis. This is palisading necrosis. The tumor cells palisade this necrosis, and the tumor cells also like more thermophic and chromatic. Okay, so actually this patient developed glioblastoma 7 years after the initial surgery. So that's why I try to highlight this case, because for gametocytic astrocytoma, this is from the journal. They said that the cutoff is 20% of more gametocytes and consider the neoplasm as a diffuse astrocytoma, which is a WHO grade 2 tumor. And some suggest that gametocytic morphology should be considered as evidence of a higher grade astrocytoma. However, there is no consensus on the percentage of gametocytes associated with a worse prognosis than otherwise expected. So from here, there are a lot of research was done actually for this they want to say that gametocytic astrocytoma is higher grade, but their findings is gametocyte can release the cytokines and growth factors and contribute to an accelerated tumor growth. So this can stimulate the proliferation and motility of the endothelial cells, and recruitment of the blood vessels indirectly facilitate tumor growth and progression. That's why from these normal gametocyte or reactive gametocytes, it can release cytokines and growth factor by itself. So that's why it contributes to accelerated of the tumor growth. So later on, indirectly, it facilitates tumor growth and progression. Okay. So for the conclusion, actually there is a sufficient data to consider gametocytes as neoplastic cells, and sufficient reason also to expect additional higher grade histological features in a gametocytic astrocytoma. However, they still need further future studies to clarify the value of gametocytic morphology as an independent prognostic factor, and also molecular mechanism that promote the formation of gametocytes. So that's why when we see a lot of abundance of gametocytic astrocytoma, we must consider a differential of tumor, at least a gametocytic astrocytoma, and we must advise the clinician to close follow-up for the patient to anticipate the progression glioblastoma, the grade 4 brain cancer. So that's the point that I tried to discuss about this case. Okay, now we go for the concept of diffuse infiltrating glioma. So this is low grade glioma, and then diffuse infiltrating glioma, they diffuse infiltrate the brain and they progress. They have a tumor progression. So that's why you can see here, this is still low grade, and then when they diffuse, when they infiltrate the brain parenchyma, then they start to actually the concept is when it locally when the tumor is there, they do not migrate, it will be multiply themselves. But when it starts to be migrate and infiltrate the brain, so it will go further. It will be extensively infiltrate the brain with all the tumor progression, with the gene mutation and so on. So that's why you see the in glioma, we have this tumor progression from low grade up to a higher grade. So with increasing the anaplasia, the cells, the promorphism, you can see here, this is very low or may not have a anaplastic looking here, and then now the progress to be more anaplastic, and this is more undifferentiated looks of the cells. And for this time, they progress, actually the genetic instability also increased. That's why it become a more cancerous. See. Next, okay, this is about the tumor progression also, the radiology finding, so you can see the progress of the tumor. Okay, for astrocytoma variants, we have a few subtypes with diffuse astrocytoma, gametocytic astrocytoma, and also anaplastic astrocytoma. But for WHO, the recent WHO classification, we don't have this. We just have astrocytoma IDH mutant. Okay. Now we try to look at next case. This is female age 70 years with right parietal tumor, and clinician asks, is it astrocytoma or metastasis? So if we look at the radiology finding, the MRI here, actually there's a multiple lesion. So it probably a metastasis, but we must remember that glioblastoma also may have this kind of radiology finding. Okay, and also this lesion. So they have here and also here. Okay. So we look at the slide. Actually, I'm sorry for this. Actually, this case I took from my previous training center. So that's why it's like this is I taken from the microscope actually. Okay, so this is under low power. You see, this is a necrosis and these are tumor cells. Further higher power, you can see these all large cells. Some have a multinucleation here. Okay, and this okay. When you look at this, you may say this is metastasis also, but still possible to be glioblastoma. Okay, because glioblastoma can mimic metastatic carcinoma as well. So, so it has a mixture of epithelioid. Yeah, we call it as epithelioid differentiation, and also a few giant cells. Okay. So the immunohistochemical stains came back as GFAP is strong in diffuse positive, but the creatine is positive. KIC7 high proliferation, shows a high proliferation index of the tumor cells. Synaptophysin negative, and NCAM or CD56 neuronal cell markers positive. So actually, why we did this neuronal cell marker is because the issue is creatine is positive in this case. So both GFAP and creatine is positive with high proliferation index. So try to prove this is try to differentiate both GBM and metastatic carcinoma. And for GBM, we need to prove that one of neuronal markers should be positive. So yeah, so our CD56 or neuronal cell markers positive. So the diagnosis come up as glioblastoma or giant cell glioblastoma or epithelioid, because it has a mixture of giant cell epithelioid in the microscopy just now. Okay, this I tried to discuss about histopathological equivalence of anaplasia in glioma actually. So we can see here the cell density is increased. This is the low grade, and then this is anaplastic, and then this is the GBM grade 4. The cell proliferation also increased with high KIC7 proliferation here. Mitosis also frequent. And then nuclear promorphism is more prominent in a higher grade. And we will find this microvascular proliferation Microvascular proliferation actually is the proliferation of these endothelial cells. So you see this multiple layered. So this we call as microvascular proliferation. Not because I know maybe some of us think that microvascular proliferation is proliferation of the small vessels, but actually for GBM we need to look at this proliferation of the endothelial cells. It become like layering like this. So sometimes it forming like glomeruloid or onion ring or anything that highlight this pattern. So the keyword is proliferation of these endothelial cells. It can become layering like this. Okay, and then necrosis. Actually, to diagnose GBM, it may or may not have this one. So either we have microvascular proliferation without necrosis, or we have necrosis without microvascular proliferation. It's stated in the WHO. But for safe part, actually we always want to look at this microvascular proliferation. But if we have this necrosis, it's much more better. So we're more confident to say GBM. For necrosis, element, actually they not specified must have this belly shedding necrosis. It can be as long as there is no necrosis, we can say GBM. But you need to correlate with other thing also. That's why I said correlation is very important. So if you see only necrosis in the case, but you don't see this cell density increment, you don't see this increase of cell proliferation, you don't see this nuclear homomorphism, you don't see any mitosis. At this one, you didn't see anything this category of these features. So you can't say it's a GBM also. So you must try to correlate what the cause for this necrosis. Maybe it's just ischemic necrosis because of the tumor size, and they have a limited space to grow, then they have ischemic necrosis. So it's not true tumor necrosis. Then that's why I said you need another correlation also with the radiology findings. So if from the MRI said yes, there are central necrosis with rim enhancement, so okay, it's enough to say this. Yes, this is a GBM. Okay. This is the SAN and Mayo scheme that adopted by WHO for glioma or astrocytomas. Okay, for WHO grade 1, pilocytic astrocytoma, WHO grade 2, diffuse astrocytoma, or astrocytoma grade 2, and this histology I already discussed in the previous slide. And grade 3, anaplastic astrocytoma, grade 4, glioblastoma multiforme. But now we call as this only astrocytoma grade 2, astrocytoma grade 3 and 4, and need a molecular correlation. I will discuss further this. Okay, next. Okay, for the term glioblastoma, actually used for tumor type and tumor grade. So actually in waste basket of all that is high grade, and there are some specific subtypes for glioblastoma. So this that I told you just now. For glioblastoma, you see these microscopic features, and then the gross features also there is a hemorrhage, and then some necrosis in the central here, and then also the radiology. It has rim enhancement, very sharp rim enhancement here, post contrast, and with central necrosis in the center. So, yeah, this is a glioblastoma. Okay, so this is a specific subtypes of glioblastoma. We have epithelioid GBM, and we have a giant cell GBM, like my case before, and you also have this gliosarcoma. Okay, so for the survival curve astrocytoma, of course, higher grade than poor survival. So glioblastoma, the most least survival, only 1.2% at 5 years. Okay, now we talk about glioblastoma. So why glioblastoma is very important for us to to diagnose? Because I found few times that we are not confident to diagnose glioblastoma, and it ended up end up patient will pass away, because our delay in making a diagnosis of glioblastoma, because sometimes there are no full microscopic features present. That's why we're quite afraid to give a diagnosis of glioblastoma. But we need to aware all these fact about the glioblastoma. So glioblastoma is the most common primary malignant brain tumor, and that lies primary malignant brain tumor, and accounting for 48% of all primary malignant brain tumors. And in the United States, they estimate more than 10,000 people die from glioblastoma each year. And 13,000, about 13,000 people in US will be diagnosed glioblastoma each year. Okay, and yet their 5 survival rate for GBM patient is only 6.8%, and the mean survival for GBM patient is only 12 to 18 months. Okay, and it also affects 3% of pediatric patient. So actually GBM also happen in pediatric patient. So survival rate and mortality statistics for GBM have been virtually unchanged for decades, and with such limited progress made in treating these aggressive and complex tumors, the time to act is now. That's why for this GBM, people do a lot of research and up to decades, to get the FDA drug, FDA approved drug. And they tried, that's why now they try to incorporate the molecular findings to give a diagnosis of astrocytoma or astrocytoma. This is I think the one cause here because of this GBM associated Lias tumor. So this is a fact for brain tumors in pediatric. Okay, so GBM develops in the hemispheres of the brain, but can also develop in other parts of the brain, include brainstem as well as spinal cord. And the most common and dead layers of malignant primary brain tumors in children. Okay, so every year up to 20 children are diagnosed as glioblastomas in Australia, and mainly children aged 5 to 8 years old. Okay, 80% of children diagnosed with high-grade astrocytoma will die, and their survival rate similar like in adult, about 15 months only from the diagnosis. So yeah, that's why like leukemia as well. So the worrying of this image of glioblastoma in pediatric cases. Okay, so this is this is a statement. Glioblastoma, they also have a glioblastoma awareness day. So they said despite first being identified in scientific literature in the 1920s, there are only 4 FDA approved drugs and 1 device to treat glioblastoma. So since 1970s, they actually only one that we use chemotherapy drug for this GBM is temozolomide. That's why we did the MGMT methylation array for this treatment. And now we have another bevacizumab. Okay, this is more for the angiogenesis drug. So these two is FDA approved drug for glioblastoma. So after how many years? Okay. So I try to share about this also, why we are so difficult to diagnose or to have a treatment for this GBM. Okay, they try to make a GBM equivalent to octopus, so they said the octopus tumor. This is actually astrocyte and then GBM tumor. So because of a few factors here, first is our anatomical location. Okay, the GBM is intra-axial tumor, so it protected by the scalp and the skull, and and they have a unique microenvironment, blood-brain and blood tumor barriers. Okay. Okay. And then second issue is inter-tumor and intra-tumor heterogeneity. So this inter-tumor and intra-tumor heterogeneity involve molecular level, cellular level, histological level, clinical and biological level. Actually, this is another big topic. So that's why I said to discuss about glioma also, it's not enough one day. It's many things to discuss for this topic. And the other factor is characteristic and tumor microenvironment. So because of this tumor is rapid proliferation, it has a rapid proliferation rate and infiltrating capacity in healthy tissues, and crosstalk between several subpopulations in the tumor microenvironment and peritumor region. It means this tumor can have like a crosstalk between them with the other subpopulation in their environment or at their peritumoral region. Okay, that's why they are highly radio and chemo resistant. That's why we are difficult to get the drug for this GBM. And then another difficulty also in GBM detection is MRI limitations, because it has the mimics like I have discussed before. It may have this mimic with metastasis carcinoma as well, lymphoma, you know. So that's the issues why we difficult to treat this glioblastoma. So I touch a bit about glioblastoma. So now we no more use the term of glioblastoma multiforme. Some people multiform, some people say multiforme. So anything, so multiforme actually refers to the heterogeneity. So in the revised 4th edition 2016 of WHO classification, the term multiforme was dropped, with these tumors referred to merely as glioblastoma only. Somewhat confusingly, the abbreviation still persists as GBM, which is stand for glioblastoma multiforme. So yeah. Okay, and then for glioblastoma, previously we know we have this IDH wild type and also IDH mutant, but now we only have IDH wild type. If IDH mutant, it no longer falls under glioblastoma category. It will be under astrocytoma IDH mutant. Okay, so then another terminology is primary versus secondary. As we know, if IDH wild type usually is a primary, it means the tumor developed in de novo. But for secondary, it's associated with IDH mutant. So it means there is a progression from the lower grade to the higher grade or the GBM. Okay. Okay, so this is MRI limitations in GBM. We see here the tumors borders are defined with irregular age. Okay, this is this actually this irregular age or ill-defined border indicate the tumor cell is migrate and proliferate. Okay, okay. Another thing is this they have this GBM, they have a predilection for spreading along the condensed white matter tract, such as corticospinal tract and also the corpus callosum. Corpus callosum, the one that connect this like right and left hemisphere. And so GBM may involve both contralateral hemisphere. So that's why sometimes when we look at radiology or MRI, we look at lesion is here, but actually when we detect this tumor in this hemisphere, the cells already proliferate and migrate to the contralateral parts. That's why it's no is patient develop a few months later, you may see patient develop another lesion here. So actually the process will start this time. Okay. So and this nature of spreading actually is similar for both GBM and cerebral metastasis. So they usually they have a predilection to growth at the gray-white matter junction. This is the gray matter, this is the white matter. So at the junction or subcortical white matter, so here, this area. So they tend to grow along this area, and then they usually also spread along the subependymal tissue. So subependymal tissue, which is beneath the ventricle. So they follow our ventricle system, and they may invade and expand through this corpus callosum to the other or contralateral hemisphere. So that's why sometimes we are difficult to distinguish between cerebral metastasis and GBM. All right, now we look at this. This is another issue also why GBM make us very difficult to diagnose them. So they have multiplicity, which is multifocal versus multicentric. So what is multifocal and multicentric? Multifocal is multiplicity is multiple. So they may have multiple tumor, multiple lesions, and this multiple lesion may be multifocal or multicentric. Multifocal, the lesions have an obvious connecting conduit exists between multiple enhancing foci through this white matter tract and CSF. So it means in this brain, there are multiple lesions with this rim enhancing, and this rim enhancing lesion are connected with the same white matter tract and CSF conduit. Okay, while for actually my circle is actually dah tersasar, sorry. So this is the lesion, this is another lesion. Okay, this is for multicentric. So we see here for multicentric, there is no connection. So it's not spread via pathways along commissural or cerebrospinal fluid channels, or local metastasis via satellite formation. So it will be not connect to each other lah. So that's how to differentiate multifocal and multicentric. Multicentric is actually rare. However, GBM may have these both features, which is common multifocal, but rarely they also may have this kind of nature of spreading multicentric. That's why still difficult to differentiate GBM and metastasis, cerebral metastasis. Okay, so now we go to the further part. It's a brain tumors revolution or diagnostics. So I try to touch a bit about the molecular and our current updates. I don't want to go too deep because it will make us scared, because the molecular advances, molecular evolution is very advanced actually. Okay, so this is a few journals associate with this evolution. So revolution, so the third promoter mutation, and then integrative genomic analysis of diffuse lower grade gliomas, and IDH. IDH is most common of among us. Okay, now this is a previous, I think this is 2016 scheme for the molecular incorporation in the gliomas. So previously we only know about this IDH status, 1P90Q, and also ATRX DP53. But this ATRX and DP53 actually is not required for diagnosis. It's just characteristic for astrocytoma, but not required for diagnosis. The important thing before this, we only do the IDH status and 1P90Q to differentiate the oligo, right? Okay, but now we have this a lot of gene mutation. So they studied the precursor cell of the glioma. Just now I already explained to you before this about the precursor glioma, And from there, they found all this mutation specific. But this also is not, this is a big study. So they found from their study that this gene mutation is associated with this type of tumor, primary glioblastoma, astrocytoma. Okay, but it's quite quite in numbers. So I try to simplify more. Okay, so when you look at this, from here, actually you may see for oligodendrogliomas and oligodendrogliomas and glioblastomas, both of them have this third mutation. The red color is a third mutation. But astrocytoma lack of third mutation. Okay. And then you see the ATRX, the blue row here. For ATRX is most found in astrocytomas compared than oligo and glio. And IDH1, 2 in the green one, it found in oligodendrogliomas and astrocytomas, lack in glioblastoma. TP53 mutation found in most in astrocytomas, and then glioblastoma, but lack in oligodendrogliomas. So you're already confused now, right? And then also the chromosome 1p90q and EGFR amplification. So actually, I want to highlight what this. I try to simplify it for you all. Okay. So this is a molecular, the simple molecular classification of gliomas. So first line, we do the IDH. Okay. So if a IDH mutation, the next thing that we must do is actually 1p90q, because IDH mutation, it falls into, it can be astrocytoma or oligodendroglioma. Okay, now how we want to differentiate these astrocytomas and oligodendroglioma? We are compulsory to do this 1p90q, and it must have co-deleted. It must both deleted, cannot either one. Then you can say it is a oligodendroglioma. If they don't have this co-deletion, then you only can say them as astrocytoma IDH mutation. Okay. Further or additional finding for this molecular classification is they found that TP53 and ATRX actually specific lineage mutation. It's a astrocytic lineage specific mutation for TP53 and ATRX is a astrocytic lineage specific mutation. So that's why if we found this TP53 and ATRX mutation is likely for astrocytoma. Okay. For oligodendroglioma, actually the most specific lineage mutation is CIC and FUBP1. And okay, while the third promoter, actually it also found in this glioblastoma. Okay, now just now I said if there is IDH mutation, the possibility is either astrocytoma or oligodendroglioma. And to differentiate both of these, we just need to do this 1p90q co-deletion. Co-deletion. So fish actually. So if we found 1p90q co-deletion, so it will falls under molecular oligodendroglioma. Now, how about no IDH mutation? So if IDH no mutation, okay, so it is likely it's molecular glioblastoma. But there are also additional mutation found, which is third mutation, and also imbalance of chromosome 7 and 10q. Okay, and also it is EGFR and P10. But we need to remember that third mutation also found in oligodendroglioma. So that's why I state the most important thing is the basic molecular for this tumor, IDH 1P90Q. And for this glioblastoma, actually this additional mutation is helpful in the difficult cases. Okay. But another thing is for TP53, it's not because TP53 also can found in other cases, so we cannot differentiate or distinguish this TP53 mutation, or is it accumulation by other causes? So it means when TP53 positive, so it doesn't exclude of other possibility accumulation by other causes as well. So that's why our first line is always this IDH and followed by 1P90Q. Okay. All right. Next, about co-deletion 1P90Q. Co-deletion of 1P90Q is prognostic and also predictive of sensitivity to activating chemotherapy. That's why we are compulsory to test 1P90Q to diagnose the oligodendroglioma. And then for GBM, we have this hypermethylation of the MGMT promoter gene. Okay, this also is a predictive and also prognostic value for the GBM. Okay, so we can see here MGMT. If patient have methylated MGMT promoter, they have better prognosis than unmethylated MGMT promoter. Usually, methylated MGMT promoter found in lower grade, and unmethylated MGMT promoter found in higher grade of glioblastoma, usually. Okay, so so here this study tried to differentiate the treatment if they give only radiotherapy or radiotherapy plus chemotherapy. So they found that the chemotherapy was also effective in non-methylated tumors. So that's why the MGMT hypermethylation appears also to be as a prognostic in the astrocytomas. Okay, next, we look at this thing. Actually, I try to highlight about okay, we know that astrocytoma happen most in intracerebral. Okay, but we also need to aware that in children, even though I'm not discuss further for children with gliomas, but just to remind, sometimes in adult, if the location of the tumor in the midline area, it means in the thalamus, pons or brainstem, sometimes we need to do this H3K27M, E3 and M immunostain to highlight the K27M mutation. Okay. All right. So we go for further case. So next case. This is a 27-year-old male with a 15-year history of multiple sclerosis. And then, okay, this is the features, the microscopy. So first picture, you see this is like a low grade, right? With a thin wall, the vessels, and then still low density of the neoplastic cells, and then some chromophytum. Okay, and then okay, the next picture is more higher density cells. Sorry. Okay. Then the last pictures is clearly show these all anaplastic cells are very large, chromophic, hyperchromatic, and the presence of mitosis here. Okay, few mitosis in this field. So yeah, it's if we don't see these two pictures, you only see this first picture. I would say it's still possible of low grade, or because the density is quite low here. But looking at the chromophysium, actually it warns us of anaplastic cells. That's why this case I highlight to explain that anaplastic cells sometimes astrocytoma. Sometimes you need to look careful. Sometimes the cellular density is not very much like this. You can be sparse like this, but it's higher than normal. But you found all these chromophic cells. The chromophysium is more than in the low grade. That's why. Okay. So when we look at the MRI brain, and then we see on the axial T2 flare here, it has some it's not the typical rim enhancement lah. Okay, it just it's also not straight away. The enhancement is not not obvious also. Okay, so that's why this case a bit tricky in the beginning. And then you see the spectroscopy actually to indicate choline peak with reduction of NAA. So usually this indicates of higher grade of astrocytoma. Okay. So for the immunostains, it shows GFAP is positive, IDH is positive, so it is IDH mutant. ATRX positive, P53 positive, and KI proliferation is about 40%. So it's really high grade tumor. So the diagnosis is IDH mutated anaplastic glioma, WHO grade 3 fevering astrocytoma. And they did 1P90Q because of the previous picture. I think this one, we saw like a vacuole, like an oligodendroglial element. So that's why they proceed with the 1P90Q and turned out to be no co-deletion detected. So we conclude the case as IDH1 mutated anaplastic glioma or WHO grade 3 fevering astrocytoma. Okay. So, this is a bit explanation about oligodendroglial lineage. So actually, if you, for oligodendroglial cells, if the tissue is immediately fixed, we actually less to see this vacuole, this perinuclear halo. But if it is delayed fixed, the halo will be more prominent. So because sometimes we have oligodendroglioma with lacks of the perinuclear halo. So that's the pitfalls, That's why the 1P90Q is very important to diagnose oligodendroglial. Okay. So we go for further case exploration. Okay, next. Case is a 60-year-old Malay man who was presented with history of headache on and off for a year and left limb weakness for a week. Okay, so this is the radiology findings. So actually I want to highlight here is the butterfly shape. This is a butterfly shape with rim enhancement post contrast, which is quite a clue for GBM. Okay. So and intraoperatively they found that it is a grayish tumor with poor interface, brain interface, and the tumor is soft and highly vascularized. So this is the radiology and microscopy findings. So we see this actually, for this case, we have two different areas. This is the first areas where we see it's like a glia. It's only straightforward glia here, okay, with some necrotic background. And then another area, we found this more towards the oligodendrogliomas with all these typical features. Okay, and there are a lot of mitosis. So it is straightforward, it's high grade. But now the issue is it astrocytoma or GBM or anaplastic oligodendroglioma? Okay. Okay. So, and we also found this, the perineuronal satellitosis, microvascular proliferation. Okay. So I want to tell, actually for perineuronal satellitosis is not a hallmark actually for oligodendroglioma because it may present in other brain lesion as well. But sometimes we just, when we found this, it just like a clue for us to think oligodendroglioma as a differential diagnosis, because we know, as I present before, this in normal glial tissue, the oligodendrocytes love to sit surround the neuron. So that's why it forming the perineuronal satellitosis, like arrangement. So that's why when it become a tumor, it still preserve this kind of architecture. Okay, so we proceed for the immunohistochemical stain. Then we found the GFAP. This is the first area with the glial loop, which is clear-cut strong positivity. But for the second area, the oligodendroglial loop, we found this is an reactive astrocyte. And then the GFAP actually more highlight the background, the glial processes, but some scattered positivity of the tumor cells. Okay. ATRX, both also retain. It just different intensity. So I also don't know why the oligo area is much prominent positivity compared than the glial area. Okay, IDH1, both also negative. So it's a wild type. Ki67 high at both area. Okay, P53 positive both area. And for S100, actually S100 stain for both neuronal and oligodendroglial element, because we don't have an olic stain actually. So sometimes I use this S100 to highlight the oligodendrogliocytes. So for glial area, it tend to be I think it's just patchy positivity. But for oligodendroglial area just now, there are some positivity here. Okay, so what is the how we approach the diagnosis for this case? Okay, first we look at the clinical information given. It is an elderly patient. It has a rapid progress symptoms. Radiologically, it is an irregular lesion with intra-axial heterogeneous rim enhancement post-contrast. So, and intraoperatively, it shows a poor brain interface, and the tumor tissue is soft with highly vascularized. So all the features actually towards high-grade intracranial, intracerebral brain tumor. Next step. Okay, this is okay. I tried to introduce with our new way of diagnosing brain tumors, what we call as layered diagnosis. Okay, so actually we start to do this layered diagnosis. It means we have all these levels. We have the histological diagnosis, WHO grade, molecular information, and integrated diagnosis. So for this case, the histological diagnosis is diffuse astrocytic tumor with oligodendroglial differentiation. And WHO grade is grade 4. Molecular information is the IDH is not mutated, so it's IDH wild type, ATRX mutant, TP50 mutant, and 1P90Q is no co-deletion, so it can't be anaplastic oligo. So it's a GBM or astrocytoma grade 4, or the GBM grade 4. Okay, so the integrated diagnosis will be diffuse astrocytic glioma IDH wild type with molecular features of glioblastoma WHO grade 4. Okay, this is okay. Actually, I have another. Later, I have another case to show how we report the case using the integrated diagnosis. My experience in Netherlands lah. Okay. Before that, I tried to explain about this. In the previous case, we have both, right? We have both glial as well as the oligodendro glial area. So previously, we might say it's a mixed oligoastrocytoma. But then, when the the time goes and they have a lot of studies, they found that actually they found that actually for this true oligodendroglioma, we must found loss 1p 90q. Okay, and then for true astrocytoma, no loss of 1p 90q. So that's why this entity oligoastrocytoma actually was abolished, I think, in the previous WHO 2016. There's no more oligoastrocytoma, if I'm not mistaken. Last is in WHO 2007. Okay, so next we go for, okay, next case is 58 years old female with right frontal tumor suspected of high-grade glioma. Okay, this is the microscopy features. This case also I taken from my previous training center. That's why it look like this lah. Okay, this is I took picture from the microscope. Okay, so this on the low grade. For this, you can see this micro classification actually. This is a higher grade also, you see this micro classification, quite prominent in this also. Okay, when you look at the tumor cells, actually the tumor cells is quite uniform, quite uniform, small, round, oval, but the thing here, we don't see obvious perinuclear halos. It's just like very mild, you cannot, like a previous case, very distinct features like oligodendro tumor. Here, it's quite tricky. There are a lot of classification. The tumor is also quite uniform, small, round, oval, but lack of these halos. Okay, so initially when we see this, we think of a low grade oligodendroglioma by microscopy. But then, when we continue with all the in Netherlands, actually in Europe, actually they are quite advanced. So most of the tumors, they are proceed with a molecular. So they, if a tumor, they straight away proceed with the neuropanel. They call it neuropanel, which they have all the mutation panel there. So very seldom to do immunohistochemistry. So from the findings there, noted this case have third promoter mutation, PTEN mutation, NF1 mutation, and also copy number deviation, which is they have loss of 3p chromosome 3p 10 17 partial, 19q partial, 22q and XP. Okay, so actually this is the real life we encounter to diagnose glioma, brain tumor. Everything is with this molecular thing. So we need to know which is the specific or more related to the tumor. So that's why we still need to correlate with the histological features. So this is we call as integrated or layered diagnosis. The first thing is this level. For microscopy level, we found it is only low grade oligodendroglioma, which is WHO grade 2. But this diagnosis is not confirmed by the molecular abnormalities. So after they did the neuropanel or molecular of gene mutation, this case have part actually loss of one pinna loss is oligodendroglioma by molecular. So that's why they make a integrated diagnosis as glioblastoma IDH wild type. Okay, and then additional that they will do this MGMT promoter lah for the treatment. Okay, so this is how they diagnose using the integrated diagnosis. Actually, this integrated diagnosis was proposed also in the latest WHO classification. Okay, but for us, okay, I understand that we have not a full establish of molecular in brain tumors, but in HKL actually now we are going to at least optimize the gliomas first. So at least we have this IDH, we have this 1P90Q, then we can provide this integrated molecular diagnosis. But if we cannot do any molecular diagnosis, okay, I go further. I think there's a paper after this. Sorry. If we cannot perform any molecular diagnosis, we need to put another entity. This also was explained or incorporated in our latest WHO. It's about NOS and NEC. I don't know whether you're all aware about this or not. So now, because we are having this advanced molecular thing, so where's center which we do not have this molecular tools, so we must put as NOS. It means not otherwise specified. So we didn't do any molecular tests to get the diagnosis. So we put GBM NOS WHO grade 4. If we did a molecular test, but we cannot classify the tumor, even though we already did the molecular. So the term is NEC, not elsewhere classified. So this is like in if you are from periphery, if you see the microscopy, very typical of glioblastoma. You see all the features. You see all the high grade density. You see all the high proliferation index, nucleopomorphism, and then you see the microvascular proliferation, and it's very clear cut glioblastoma. But you don't have IDH. You don't have all the molecular tests. So you may diagnose as glioblastoma glioblastoma NOS WHO grade 4, and you can send for further molecular additional molecular tests. Okay, so that's the option. So because we don't want to delay the patient now if we refer the case without say something to the clinician. Okay. Okay, this is about tumor heterogeneity and sampling error. Okay, this is another explanation why, especially for the previous case, the morphology looks like only low grade, but suddenly the molecular show is a high grade tumor. So this is the possibility. It's about tumor heterogeneity and sampling error. So as I explained before, glioma is very, I would say, an intelligent tumor because they can have heterogeneity among the cells, among themselves, So if clinician took a sample from this, so this is the main bulk of the tumor with this rim enhanced post contrast, right? And then this is like a solid cystic in nature, and then this is the area at peri the tumor, and this is quite far away from the tumor. But you see here, actually, even though it's away from the tumor, this area, there is a peri-regional edema. We call it as peri-regional edema. Actually, even though it's not at the tumor, it might show some changes here. So that's why you look at the microscopy, you see the edematous microscopy. Yeah. So and this you can say if you get this area, if surgeon take sample from this area, you may say this only reactive, maybe microscopic morphological description, because of you cannot say what is it neoplastic or non-neoplastic, and you will miss the GBM. Okay, when surgeon took from this at peri tumor, it's not tumor, this peri tumor, the features is like this. Okay, this is because lesion has a peri-regional edema, so still they have edematous area here, but the cells are more atypical compared than the previous one. Okay, with all the reactive gametoscytes here, and the cells also more hyperchromatic, so the atypia is more. But if they took from this actual really at the tumor, okay, at the target, then you will see the full blast of this glioblastoma microscopy features. So that's why sometimes it's very tricky to diagnose GBM microscopically. So that's why I always tell myself, if you want to diagnose astrocytoma, especially, because we know about this heterogeneity, we always need to look back at need to correlate everything, include the clinical progress and the radio findings, and the radio finding, clinical progress, and then all the radio, everything. We need to correlate everything. We cannot only from the microscopy features, then we conclude, yes, this is, example, we just diagnose is this reactive or non-neoplastic. So we are already miss the patient. So that's why sometimes if I saw the radio and the clinical is intraoperative, all is very suggested or highly suggested of the high-grade tumor, but microscopy is only like this, it's not suggestive or high-grade at all. So I always put comment there that this area could be missed or undersampling. So we try to discuss with the surgeon where actually they took out the sample. Okay, it's possible of sampling error. And that's why the molecular investigation is helpful in this type of case, like previous case. Even though the microscopy show a lower grade, but then the molecular turned out to be the high grade, is a glioblastoma. Okay, that's another reason. So this one is WHO 2007. It says that grading is based on areas showing the highest degrees of anaplasia, on the assumption that this tumor cell population eventually determines the cause of disease. Okay, this one actually, this one I tried to explain about just now, NOS and NEC. That's why I explained just now. For WHO classification, they have a background of DC impact now. Actually, DC impact now is a team. These people, the team, they will meet, discuss, to evaluate a brain tumor. They did quite well advanced molecular investigation, everything for brain tumor classification. So I already explained about the use of NOS and NEC designation. Okay. So now we go, okay, we already at the end. So the summary. So for brain tumor, it has a evolution from the histomolecular pathological diagnosis to therapeutic management. Okay, so the pathological diagnosis of CNS tumors is actually a multi-step process, starting with the tumor tissue. Okay, sometimes we do the frozen tissue as well, and in some cases also blood samples being analyzed with multiple tests to provide an integrated diagnosis, evaluation and discussion, okay, of multidisciplinary board of specialists from radiology, surgery, oncology, and neuropathology is crucial for translating the findings into optimal management for individual patients. So that's why this concept is very important to diagnose the brain tumors. Okay, so this is an illustration of integrated workflow for pathological diagnosis of CNS tumor from the morphological patterns and IHC profiles. Then we incorporate also the detection of key mutations, the copy number variations, fusion genes, etc., and in the selected gene sets. And this is the next generation sequencing. This is I told just now in Europe they did this NGS or next generation sequencing, which include all these key mutations. Okay, then they also did this one methylation profiling. So this one it matched with established profiles of over 80 CNS tumor classes, as well as information on CNVs and copy number variations and MGMT promoter methylation status. So yeah, they are already until this level, but we are still towards this level. Okay. Okay, so as a take-home message, the pathological diagnosis of CNS tumors is a multi-step process with multiple tests to provide an integrated diagnosis. So evaluation and discussion of the pathological diagnosis by multidisciplinary board of specialists from radiology, surgery, oncology, and pathology is crucial for translating the findings into optimal therapeutic management for individual patients. So that's why in Europe, when my place, previous training place, they have the like a CPC or board, multidiscipline board meeting every week. They discuss all single cases on how they want to manage the patient based on our pathology findings. Okay. So okay, this is I just share a few pictures of my previous place. This is Princess Maxima Centrum, is pediatric oncology center in Utrecht. So this place is focused on the pediatric cases only. They have their own molecular lab. Everything is here. Okay, and this is the Princess Maxima Center. This is my main training place. It's Rasmus Medical Center. So and this is my supervisors. This is my supervisors that with all this molecular and oncology CNS. This is my main supervisor, Prof. Pros M. Johan. This is Prof. Peter Westling. Actually, if you aware, the previous papers all in NC Impact team also actually both of them are involved in C Impact team, C Impact Now team. He is focused on the pediatric neuro-oncology, Prof. more on the adult. And then this is Dr. Rob, also neuropathology, also ophthalmopathology and muscle pathology. This is Dr. Eric Eric Dubing. Actually, he is a molecular person, which I always consult for how to report the molecular finding. Because first I look at the report, I was a big headache to see all the mutation which I don't understand. So I try to learn slowly with him and correlate with all the clinical. So that's all. I hope I'm not make you all more confused with the CNS tumor. I try to simplify actually, but I'm sorry if I couldn't, but that's the best I can give to you all. So yeah, that's all. Thank you.
Thank you, Dr. Haizura. We have questions from the participants. I'll start with the first one. First one is, what are the specialized IHC, ISH tests and molecular testing included in the
Wait,
cancer?
Dr. Zara, actually I cannot hear you well. So slow your voice.
Okay, I'll talk so louder. Okay. The question is, what are the specialized IHC, ISH tests and molecular testings, including the cancer panels, mutational testing, either single molecular or multiplex testing, molecular sequence available in HKL, and the National Reference Genetic Lab Tuanku Aziza?
I didn't hear. Wait.
You can check as well in the chat box.
Chat box. Wait. Okay. Is it this one? What are the specialized IHC?
Yes.
Each test and molecular testings, including the cancer panels, mutational testing, either single molecular or multiplex testing, molecular sequence available in HKL and the National Reference Genetic Lab, Tunku Aziza Hospital KL for CNS tumors. Okay, it's quite long question. Actually, okay. We don't have a complete panel yet. Actually, we do have the IDH PCR now. We also do have the 1P90Q fish. Okay, and we are going to have the MGMT methylation profile as well. That is the basic thing that a molecular test we have for the CNS tumor. And it was done in a molecular lab HKL. I'm not sure about genetic lab Tuanku Aziza. Okay. Then the next question. In our settings now, which situation are recommended to do molecular tests in glioma? Since now the WHO classifications in glioma molecular overall morphology. Okay. Actually, as I explained in the lecture, actually, we not, the molecular findings overall morphology if they took sample from, not from the actual tumor actually. So for basic concept to diagnose gliomas, we still need to correlate the morphology, radiology, the basic, the classic concept. So for molecular testing, it more on the prognosis and also for the treatment purpose. The basic thing that I suggest is IDH, of course, to differentiate between the mutant or wild type. And then the next thing, the important thing is 1P90Q. In some cases, if not straightforward, then we could add further molecular tests. For example, if ATRS MP50, we have the IHC, so no problem. The EGFR, that one is we don't have the IHC, so that one is need the molecular tools. Like we don't have the PTEN, we don't have the third promoter as well. So that's what our limitation now. But what I'm going to to try to develop, to establish our molecular test for CNS. But for the basic thing, we have it in HKL. Okay. So next question.
One question from Facebook. From Dr. Nohayati. Can you share role of MGMT methylation in your training center? What are the indications? Is there role in young patient?
I couldn't hear.
Oh,
What
okay.
is it?
Kejap. Tak dengar
Very, ah,
What is wrong here?
What is the role of MGMT?
role of genetic.
MGMT. Methylation.
Hello, dengar tak?
Tak. Ke type dekat chat box tu.
Okay lah, Zara type.
Perlahan sangat-sangat. Oh, what is the role of MGMT? Okay. Dr. Su. Oh my God. Actually, MGMT is another in my previous training center, we used to order MGMT for treatment actually. So they did for more than 65 years old patient. They will do the MGMT. But in less than 65 years old, actually they straight away do the MGMT because actually MGMT give a benefit to young patient because they assume that young patient most common to have the IDH mutation.
Hello.
So actually it correlate with the IDH mutation. That's why for more than 65 years old, we do the test first. If MGMT methylated, then we will proceed for the treatment. But if not, then we will not proceed. So it's associated with that. So, okay. What is the indication and is there, okay, I have answered that, right? What is the indication and is there a role in the young patient? Yeah, because actually it's associated with the IDH. Actually, it's another topic for MGMT. Yeah, but I couldn't, because a quite big topic because I need to explain the molecular pathway and then we understand how it works. So, but basically there in my training center, they will do MGMT test only for more than 65 years old. But if less than 65 years old, they assume that patient have IDH mutation, so they didn't did the MGMT methylation profile test. Okay, because MGMT, they use another method in methylation profiling. So it is very expensive and we have here as a PCR, right? Okay, so maybe can slot for next year. Then we need to talk about only molecular because it's a very big topic also because I need to explain the pathway, then you can understand how it works. Okay, so I cannot. So today I'm more focused on the basic pathophysiology actually, and then a few tips how we differentiate the diagnosis. Yep. Okay. Are there any question more?
Kejap, tengah type.
Yeah. So we have here, we have the PCR MGMT. We have the PCR IDH, and we screen. For IDH, what we screen before doing MGMT. Oh, okay, I just answered Dr. Su first. Yes, we have here in HKL PCR method what we screen, but we screen before doing MGMT. Yes, but actually, I don't know how the oncology protocol here. So that's why how they treat the patient with glioblastoma. What is their standard protocol? So that's why we didn't do for all patients. Yeah, it's correct. We need to screen before doing the MGMT, but we must do correlate with the oncology protocol. Okay, so that's the MGMT issue. And then for IDH, need either one, IDH1 or 2 or both. Okay. Actually, okay. Okay, I answer Dr. Faizal first. For immunostain, for me, it's enough to do for basic thing. It's good if you all have IDH1 IHC, okay? Because IDH1 is a higher percentage mutation compared than IDH2. That's why we advise at least you all have IDH1 IHC. If it's tend to be negative, then we will proceed with the IDH PCR. So our PCR in HKL, it covers both IDH1 and 2. But for IHC, is either one. So, and it's it's quite difficult also actually to optimize the IDH2. So my suggest at least you have the IDH1 IHC, and if we return to be negative and the morphology is not correlate with your diagnosis and you want to proceed with IDH PCR, then you may refer case to us lah in HKL. And then next question. Okay, and then some oncology ask for MGMT but some no. Yeah, that's why Dr. Su I want to discuss about this also. Need to, because I already asked the oncology. Actually, they don't have a neuro oncology, what I've understand. So that's why maybe the treatment also not standardized. So it's supposed to have one standard, protocol for this. So maybe we need to sit down with them and discuss so we can have a protocol, better protocol for MGMT profiling, MGMT methylation. Okay. Then next question. Are we going to do IDH molecular testing as reflect testing as we do for GFR? Okay, for EGFR. Yes, for me, IDH molecular testing is reflect testing for gliomas, especially astrocytomas. Yep. That's why I advise if at other hospital we don't have the molecular tools, at least we have the IDH1 IHC. All right. Okay. Then MGMT pyrosequence, yes, correct. It's an expensive test. That's why in my training center, they didn't do pyrosequence anymore. They have the methylation array. So it's more expensive. So that's why we need to really justify the indication to do this MGMT. So that's why I'm thinking it's good for us to have like a roundboard discussion with the oncology as well as the other clinician team, because we need to know how they treat the patient also, because MGMT is towards the treatment, and so that's why this is need for the discussion actually. Okay. Is there targeted therapy available in CNS tumor? If yes, what are the markers or molecular testing required? Targeted therapy, I don't think so, because they only did they have the temozolomide and then they have the immunotherapy actually, but that one is for young patient with high grade astrocytomas. Okay, for targeted therapy, I also don't aware about this so far. Maybe still in research progress. Okay, and then then I don't.
I think that's all the question. Dr. Farah Sofia has raised her hand. You want to ask question?
Farah Sofia. Hmm.
Dr. Farah Sofia.
Mana Dr. Farah Sofia? Let's see Dr. Farah Sofia. Hmm.
Baik. Okey.
Saya dalam chat box juga. No more question on the chat box. In the chat box.
Setakat ni tak ada. Kat Facebook pun dah tak ada question lah.
Ah?
Saya dah message Dr. Farah Sofia, dia tak ada jawab apa-apa lah. At the moment, yeah. Anything Dr. Haizura wants to, advise, or let's say kalau orang nak refer, what do you advise to them if they want to refer to you?
Alamak, apa tak dengar?
Saya dah tukar mikrofon, macam-macam mikrofon dah ni.
Mikrofon apa?
Referral.
Dr. Aizura, can you hear me? Dr. Zara tanya, what can you advise if anyone would like to refer case to you?
Oh, kalau nak refer case
Ya.
SPL.
Ke Dr. Haizura tu lah.
Refer case Zura. Refer case. If you nak refer case, I happy to accept. Cuma the most important thing, I would like to have the radiology finding, and it's good if you know the intraoperative finding as well. And then, but I actually I'm okay if you are not sure, you can call me anytime or text me anytime to ask, because sometimes it depends on the cases also. It's not straightforward, sometimes they have usually they call me and I will ask through the phone straight away. So from there I can advise what another another thing that I want. So for me, I'm quite flexible. In any way you can refer to me. Okay. Then MGMT is for treatment. If mutated, more effective for temozolomide than not mutated. Yes, correct. That's why they said the most mutated is in adult in the younger age. So that's why for more than 65 years old, most of them is wild type, right? Not mutated. So they proceed the MGMT methylation profile for this age group. That's the indication. So that's why I don't know what is the cut-off age that oncologists in here. Which age? Is it more than 65? But in my place, is they take a 65 years old as the cut-off age. Okay. Any other question?
Any other question?
No more question, is it?
Ada question ke? All right. I think we shall end the session now. Thank you once again to Dr. Haizura for very informative talk. I think we've learned a lot today. Okay, see everybody maybe next month, not maybe lah, next month. With another talk, this time around by Dr. Salimia from a perinatal pathologist on about things that you should not miss while looking at placenta. I think going to be a very good, even great talk. We'll wait for next month. Thank you everybody for your patience and cooperative and understanding. See you next month.
Okay, thank you too.
Okay, thank you. Bye, Haizura.
Bye bye. Thank you very much. Bye bye. Thank you, Kak Zara.
Thank you, Zura.
Thank you, Doctor. Bye bye.
Thank you, Dr. Raini, assisting masa microphone saya out. Hmm.